So welcome everyone to today's webinar in which we are launching our latest report, Saving 4.6 million lives in Indonesia, the impact of complementing tobacco control with harm reduction and improved lung cancer treatment by 2060. Here is a copy of the report. And you can get a copy of this report on tobaccoharmreduction.net under the resources tab, and also look out on our social media channels. So I will now play a video that features the two leading report authors, Dr. Delon Human and Dr. Derek Yach, who will discuss the report's methodology, its significance, and key findings.
Good afternoon. We welcome Dr. Derek Yach, who's the project leader and lead author of the Lives Saved study on Indonesia. Now, Derek has had a storied career in public health, working in both the public and private sectors, and particularly his years as WHO director when he was one of the architects of the Framework Convention on Tobacco Control is highly relevant to the study. Dr. Yach, welcome to this launch. Derek, I'd like to ask firstly more about the methodology of the study and would appreciate if you could just explain the significance of this within global public health.
Thanks, Dylan. Well, the fact is we still have 8.5 million people who die annually because of tobacco. We know that the progress guided by WHO and the Framework Convention has been slow and steady. And it means that over the next few decades, while we will continue to see declines in the deaths and disease associated with all forms of tobacco, it's not happening at a pace that most people would regard as acceptable. I think that the advent of tobacco harm reduction products over the last 10 years, and by those I include the full spectrum of heated tobacco products, snus, nicotine pouches, vapes, and now more recently electronic shisha, give the opportunity to remove what really causes the deaths, namely the smoke, the combustion, and through using nicotine, no different from what we have in nicotine replacement therapy, the opportunity for people to live healthy lives and be off the part that's going to kill them. That's the significance of it. And the study really asks the question, as we have in many countries, how many lives could be saved if governments, consumers, and society were to implement the use of the currently available tobacco harm reduction products beyond the expectation of what we'll see by using the WHO status quo approach. And we do that by using a range of modeling methods that I think are well described in the methods sections of the reports.
Derek, and you and I were working together while you were at the World Health Organization and I was at the World Medical Association when the framework was being designed. At the time, harm reduction was not on the agenda at all, but yet it is mentioned in the Framework Convention under Article 1D. Can you perhaps enlighten us on why it was never elaborated upon?
I think, first of all, why it was there in the first place was that people often don't realize was because we were at the start of a massive push on HIV/AIDS, and we knew that harm reduction for HIV/AIDS mattered. A range of strategies were going to actually save lives. And we saw the analogy one day for tobacco if the innovation actually happened. Why it's never taken off? Well, I think in reality, many countries it has taken off. It's that WHO has not put their stamp of authority behind it. And we describe in the report how countries like Japan have cut their smoking rate by 50%. Sweden is getting close or under 5%. UK, USA, many European countries, Philippines, they all are getting into the issue of tobacco harm reduction, almost despite of what WHO says. And our hope is that in time, we will actually see them embrace this because of the massive life-saving potential.
Have you been surprised by the speed of innovation over the last 10 years, especially?
Yes, I have. And I think our own failure was that at the writing of the Framework Convention, the words patent, innovation, technology change don't appear once. Yet our colleagues in the HIV/AIDS world were finding antiretrovirals. The vaccine world was taking off. I think we took our eye off the ball a long time ago and felt that anything that may be innovative from the tobacco industry would actually be innovative to sell more tobacco products, not to save lives. That was the fault that we all made.
Interesting. Now, Derek, in Indonesia, in the report, it shows quite a dramatic potential saving of lives. Can you perhaps elaborate on why Indonesia is probably the most significant study done so far in the series?
Yes. Well, Indonesia is the largest country in the world for which we are still seeing smoking rates going up, not down. And the numbers are staggering. 65% of men smoke, a very high significant a percentage of doctors smoke. 300,000 people die of tobacco every year in Indonesia. That alone justified a real push on it. At this time, we think there's a real opportunity with the new government having just come in, for them to hopefully take a fresh look at how they might accelerate change and leapfrog over many of the other countries, knowing particularly that they have an advantage maybe in not being a signatory to the WHO Framework Convention, and that unfettered, they can use what many of the companies and innovators already active in their country are trying to use around the world. I think it's a good time for the new government. And I think all the signs are that they're very committed to public health. Literally, in the last few weeks, we've seen them very active in tuberculosis control, in addressing access to healthcare services, and in leading a regional initiative to end cervical cancer through vaccines. On the tuberculosis side, people are often surprised when I talk about it in the case of smoking. Well, Indonesia has about 850,000 new cases of TB every year, and we estimate that 25 to 30% are caused by tobacco. Yet there have been very few efforts to place tobacco cessation and harm reduction programs within TB clinics. When we looked at the numbers, as I said, we calculated, first of all, we needed to know how many people are dying of tobacco today, and that's 300,000. WHO estimates that by 2060, which is a few decades off, if they go the way that WHO hopes, they'll be down to about 225,000. So that's a drop of 75,000. Our models suggest that if you implement tobacco harm reduction, and remember, it takes time to get them up to speed,
Yes.
that 225 will go down to about 110, 120, or halving WHO figure. And if you add in better cessation and better treatment of lung cancer, which is very likely to happen, we'll get down to about 80,000 a year. Now, those numbers are just very big, and one way to capture them in a summary form is to estimate that over the course of time until 2060, 4.6 million lives will be saved beyond what we expect from a WHO initiative. 4.6 million lives. There is very little that the government of Indonesia could do that would even come close to having that impact on their population. And we know in the report, and many of our authors from Indonesia stress the fact that while this has a huge economic and personal toll, it also takes an enormous economic toll at a time when the government is focused very heavily on economic development and prosperity. So again, 4.6 million lives will be saved. And when people say, well, then what can they do? And I'll leave it to my Indonesian colleagues to go into detail, but there are a few practical things. First, I think that the new government has a real opportunity to stand back and say, well, all these countries around the world, as I mentioned, from Japan to Sweden to the UK to the US to the Czech Republic to Pakistan now, are starting to implement the use of tobacco harm reduction. They believe that the science is sound. The US government clearly believes it's sound, otherwise they wouldn't be authorizing these products. Why don't the government appoint a commission to actually review the evidence and use local expertise in Indonesia? And we know that there's excellence in Indonesian expertise, informed by the best international advice, to produce a report independent of everybody to say, what is the evidence saying and how can we actually go faster? I feel very confident it will start off by saying, let's work with the physicians. Let's go to the TB clinics and apply smoking cessation among those almost 1 million TB cases we see every year.
Yes.
Let's work within the primary care setting where we're missing the chance to provide treatment and advice to hundreds of thousands of people coming forward with early heart disease, early lung disease. This would be one of the most cost-effective ways of reducing the death and disease from these conditions. So I would say that the role of the physician, the role of governments through the health ministry becomes vital. And the only other thing I'd add is that we've learned worldwide that everything that government does to make the healthier choice of harm reduction, the easy choice, through regulating proportionate to the risk, matters. In practical terms, it means that pricing or taxation on these products needs to be substantially more affordable and substantially less than cigarettes, which you actually want to eventually destine to history.
Eric, you've mentioned the staggering total of a potential of 4.6 million lives that can be saved up to 2060 if harm reduction were to be integrated into tobacco control. And the report highlights the health professionals' role, and you've spoken about the physicians. A question about the Royal College of Physicians report and the role it played in the UK. Do you think that there would be value in an Indonesian equivalent of the Royal College to do a similar study on the Indonesian situation?
Yes, I've always been a strong believer since my days at WHO of knowing that country ownership starts with people seeing data from their own country delivered by their own scientists in a format that makes sense within the context of all the other competing priorities. And that's why I would say that using the Royal College of Physicians as a backdrop, maybe even seeing whether one of them would come onto an international advisory board, the other very good international advisors, if this report was felt to be really owned by the people in Indonesia, I have no doubt it's going to come up with conclusions not very different from the Royal College. We must remember there were some errors in the Royal College that Indonesia could go beyond. One was a very strong, almost total focus on vapes, often at the cost of heated tobacco products, snus, nicotine pouches, and what else is available. Things have moved on since then. But there's no question in my mind that a scholarly, academic, independently scientific report has huge implications of galvanizing the political support, the scientific community, and the physicians behind such a report. And remember, in the end, we want the millions of physicians to feel comfortable in actually advising their patients who smoke to try tobacco harm reduction products, because once they start doing that, they will be reaching millions and millions of people.
Thank you, Derek. A last question on policy. You mentioned the need for risk differentiation in policy to make sure that people who smoke are incentivized to use smoke-free nicotine alternatives. Apart from taxation, are there any other ways in which policy can be used as an incentive for people who smoke to change?
Yes, I think that one of the most important concerns we have is disinformation. We have around the world considerable disinformation where physicians, including in Indonesia, believe in very high majorities that nicotine causes cancer, which it doesn't, or that many of these harm reduction products are as dangerous or toxic as cigarettes, which they are not. A very important way of actually differentiating policy is to make sure that you have clear messages about the benefits of harm reduction and nicotine for people, adults trying to quit or reduce their smoking rates, as opposed to the traditional WHO type warnings on the combustible cigarettes. You cannot have a single plastered message saying all of these products are addictive, because all that does is it confuses the consumer into thinking, well, if everything is equally bad, why don't I just continue with my tried and tested cigarette?
Dr. Derek Yach, congratulations on a fine report relevant to our time and especially for Indonesia. Thank you very much indeed.
Thank you.
Hello everyone, I'm Amalia from Dental Faculty Universitas Padjadjaran, Bandung, West Java, Indonesia. I am a dentist, lecturer, and researcher. I'm actively involved in advocating tobacco harm reduction in Indonesia. The detrimental effects of conventional cigarette smoking on oral health are already well known, from benign to life-threatening diseases such as discolorization of teeth and dental restoration, bad breath, taste and smell disorders, impaired wound healing, periodontal disease, short-term and long-term implant success, oral mucosal lesions such as smokers' melanosis and smokers' palate, and potentially malignant lesions and oral cancer. Smoking is still a problem in Indonesia with a high number of consumers. Approximately 57 million smokers in Indonesia comprises of 63% of men and 5% of women reported being smokers, a total of 37.6% of the whole population. Recently, alternative tobacco products are gaining popularity all around the world, including in Indonesia, such as heated tobacco products, vape, and snus, and it is claimed as less harmful or reduced risk products. But who knows? Is the evidence convincing? Studies carried out in dentistry evaluating the smokers who switched to alternative tobacco products or combustion-free nicotine delivery systems revealed that they demonstrated a reduction in the prevalence of micronucleated cells in buccal swabs, indicating that switching to alternative products may lower the prevalence of oral cancer. Smokers who switched to alternative products had no discolorization of teeth compared to those who continued to smoke, and the gum of smokers who switched show improved gum response to bacterial plaque challenge compared to those who continue to smoke. In addition, smokers who switch to alternative products tend to have lower plaque accumulation than smokers who continue to smoke. Unfortunately, there are still significant misconceptions about nicotine and tobacco harm reduction among both physicians and the public in Indonesia. As a researcher and educator, I recommend that the stakeholder or the authority or the government apply evidence-based policy. These alternative products may benefit us in decreasing the prevalence of oral diseases related to smoking, as well as helping smokers who are unwilling to quit or are not able to stop.